We're going to see the aortic insufficiency. The aortic valve insufficiency, also called regurgitation of the aortic valve, is when the valve doesn't close very nice. This is right atrium, right ventricle, left atrium. Something like this. We have the valves, septum, and the aorta is like this. Alright, and here we have the aortic valve, like this. It is not closing completely. Alright, so we can have many pathologies associated with this. Could be usually is isolated, but could be associated with Marfan syndrome or a aneurysm of the aorta, a syphilic aneurysm caused by Treponema pallidum, in which we have the aneurysm, and the aneurysm is here in the root of the aorta, here, close to the valve, and as the aneurysm grows, it dilates the valve, and so it could not close completely. Alright, whatever the cause be, we have the blood that goes from the ventricle to the aorta in the ejection phase is completely normal. The problem is when the valve should be closed, that is in the diastole. In the diastole, the ventricle is first in isovolumetric relaxation and then the filling from the atrium to the ventricle, but here, because we have the valve is not closing completely, the aorta also is going to give blood to the ventricle. So we have increased left ventricular and diastolic volume. At the end of diastole, we will have more blood because the aorta is also giving blood to the ventricle. So the end diastolic volume is increased. Next, the stroke volume is increased because we have more blood in the ventricle. We are ejecting more, so stroke volume is increased. The end systolic volume is the same. We have more end diastolic volume, but we are also ejecting more. So the difference, that is the end systolic volume, is the same. Next, we have so end systolic volume stays the same. Next, the ejection fraction. Ejection fraction is the stroke volume divided by the end diastolic volume. Usually, this is a little increased ejection fraction. Next, the end diastolic pressure of the ventricle. End diastolic pressure is usually normal. We have more blood, and that blood produces an increase in cavity size of the ventricle. We have hypertrophy of the ventricle. The sarcomeres are putting in they are putting in series, like this series. So we have dilating the chamber, and it is not usually the pressure. Usually, no, would be unless it is very later, but usually the pressure is normal. We just have more volume for the same pressure, so the end diastolic pressure is normal. And the pulse pressure, this is the pulse pressure is the difference in the pressure of the systolic pressure, that is the ejection, systolic pressure minus the diastolic pressure. Here we have increased systolic pressure because we have more blood that the ventricle has to expulse. So the systolic pressure is going to be higher, and the aorta is going to have more pressure because as the aorta gives more blood to the ventricle, that is, in diastole we have the same volume that the atrium is giving to the ventricle is the same volume plus the volume that the aorta gives to the ventricle. So now when the ventricle ejects the blood, now the ventricle is ejecting the blood of the atrium plus the blood from the aorta, so it is more than usual. So we have an increase in we have increased systolic blood pressure, and because the blood is returning to the ventricle at the beginning of diastole and all in the diastole, the diastolic pressure decreases. So we have increased systolic pressure and decreased diastolic pressure. This leaves us with a very increase in pulse pressure, and this increase in pulse pressure is felt. The patients feel that increase in pulse pressure as head bobbing. This is that the head moves a little with the beat of the heart because the pulse is rising and falling very abruptly. Also, we can feel that pulse in the femoral artery or in the popliteal artery or in the or feeling the collapse of the carotid arteries, that is in the diastole. We could feel that it collapses. The collapse in the carotid is called Corrigan sign. The femoral is called the Touré-Sietz sign. This is called Licon's. There are many others, but here the point is not to know all of them, it's just to know the pathophysiology and how it's going to be the pressures and volumes in this condition. And also we have the pulse beating in the nails. This is Higgs sign or pulse, that we feel it in the nails. Yes, usually it is like this. The aortic insufficiency, the goal of treatment is, if don't, we could do replacement of the valve, but also the problem is that we are having more blood that is coming, blood that is coming to the ventricle. So the goal is to diminish the blood that is coming to the ventricle. That is, if we vasodilate, we have less return to the blood to the heart, and the aorta is also going to dilate a little, so the blood is going to go through there. Also, we are decreasing the afterload, that is that the ventricle can send more easily blood to the aorta. We can do that or give ACE inhibitors in order to decrease the pressure of the aorta, the systolic pressure. We want to decrease the systolic pressure. Decreasing the systolic pressure, so we would give some ACE inhibitor. So it would be like the treatment. The murmur looks like this. Here we have S1 and here we have S2. S1 is the closure of the auriculoventricular valves, and S2 is the closure of the semilunar valves. But we don't have the closure of this valve. So through S2 we are, so in S2 is the closure of the semilunar valves. Here we are not closing it. So from S2 to the next S1, this is diastole. We would listen the murmur. And from S1 is just the closure of the auriculoventricular valves, and then from S1 to S2, this is the systole. In the systole, we would not listen anything because there is no problem. The problem is from S2 to S1. S2 is when the valve should close, and it is not closing, so it's from S2 to S1. This is a early diastolic murmur. Actually, it does not begin exactly at S2, it's a little more like this, but it's very early. So it is a early high pitch blowing murmur, diastolic murmur. Now the pressure. So the pressure in the ventricle is going to be at the beginning is usually not increased. The end diastolic pressure is not increased, but as time goes by, the end diastolic, the pressure of the ventricle, systolic and diastolic pressures are going to be increased both in the ventricle, because we have this systolic pressure is because we have to send more blood. At the end of diastole, we have like an increased afterload, that is the blood that we need to eject. And in diastole, the diastolic pressure is because in diastole we have more blood coming to the ventricle. So this is for the ventricle, and for the aorta, as we have more blood coming to the aorta, we have increased systolic blood pressure of the aorta, but because now in the diastole the blood from the aorta is coming to the ventricle, we have decreased diastolic blood pressure from the aorta. Now the pressure volume loop, this is here we have pressure, here we have volume. Let me put one normal pressure volume loop. Well, more or less like this. I do not draw very nice, but let's take that. And now we say the end diastolic volume is going to be increased. So instead of beginning here at the end of diastole, we begin here. I'm assuming that we already know how to interpret this pressure volume loop. Alright. So we begin here at an end diastolic volume later. And the stroke volume is going to be increased, but the end systolic volume is going to be the same. So it is like this. We have increased stroke volume, the difference between this and this. So the difference between this and this is greater. The stroke volume increases, the end diastolic volume increases, but the end systolic volume stays the same. We say the pressure usually stays the same, so the pressure usually like the same. Pressure is almost the same, sometimes like the same. Other people say that this increases a little, and because this increases a little, the difference between the systolic pressure of the ventricle, yes, the systolic pressure of the ventricle increases, and the of the ventricle or of the aorta is the same. The diastolic pressure of the ventricle is also a little bit increased. Oh, well, here I should have drawn it like this. Like this, I didn't mean to draw it like that. Oh, well, that. And so it's the most important thing is that in aortic insufficiency is kind of like that if we are moving the loop to the right. That is in resume, or in summary, the change in the pressure volume loop.